Okay, well, I hope you can see my screen, and good afternoon, everyone, and welcome to Pediatric Teaching for today. I wanted to talk today about epilepsy in children. It's a very common problem, and as pediatricians and pediatric trainees, we all have to be conversant about epilepsy and about how to look after children who have epilepsy, because we're in any district or provincial hospital, there'll be a number of children who have epilepsy, and most of them, they'll be reasonably easy to control their seizures, and some will be more challenging. So epilepsy is a really important topic for pediatricians to understand. I'm going to talk a bit about these aspects of epilepsy, and I'll start with, I won't go through all these, but we'll go through them as we go. But this is the nature of the talk today. To define epilepsy is important, and it's important that it doesn't just mean having a seizure. And the international definition of epilepsy has been stood for a very long time, and it includes at least 2 unprovoked seizures occurring more than 24 hours apart. So what that means is complex. You need to understand that what an unprovoked seizure means. It means a seizure in a child doesn't have any other reason for having a seizure. So it's understandable if a child's got meningitis or has got malaria or head trauma would have a seizure. That doesn't make epilepsy. So it has to be an unprovoked seizure, and it has to be at least 2 seizures more than 24 hours apart. Now, sometimes we even struggle to recognize seizures from other forms of neurological movement, and sometimes it's difficult to do so. But, oh, excuse me. Hello, it's Trevor Duke speaking. Hello. So when we are looking at a child who's got abnormal movements, consider whether it's the same muscle groups moving repetitively each time, and consider whether those abnormal muscle groups, those abnormal movements, are suppressible by tactile pressure. Seizures are not suppressible, and nor are they stimulatable. So if you touch or move a patient's limb and then they start to go into spasm, it's more likely that reflects clonus or some sort of myoclonus than it does a seizure. So that's how to recognize a seizure from other neurological movements. But epilepsy itself, the seizures have to be unprovoked. That is, not provoked by fever or meningitis or some other brain injury or some other brain insult. This is important, and there has to be more than one, and they have to be separated by at least 24 hours. I wanted to talk briefly about febrile convulsions, not because they reflect epilepsy, but often we mix up the two. And febrile convulsions are, of course, very common. They occur in around about 5% of all children, so 3 to 7% of all children will have at least one febrile convulsion. And they occur between the ages of 3 months and 5 to 6 years, up to about 7 years, but not beyond that, usually for febrile convulsions. There's often but not always, a strong family history of febrile seizures. At least a quarter of all children will have some family history of a parent or another sibling having febrile convulsions. And in about 4%, there's a history of epilepsy. There is a genetic link in febrile convulsions, but not all children who have febrile convulsions have that genetic link. There's no one particular gene or gene defect that causes febrile convulsions at all, but there are some families that have more febrile convulsions than others. Most children have simple febrile convulsions. I'll explain what that means, but about 20% have more complex febrile convulsions, so longer than 10 or 15 minutes, and they're focal, not generalized. About a third of children, 35%, go on to have further febrile convulsions. So if you've had one, then about a third of children will have another one. So that means you can tell parents that most likely it's going to be a one-off episode, but maybe 35% will go on to have another febrile seizure. Most children who have febrile convulsions don't go on to have epilepsy, but some do. And they're more particularly children who've had complex febrile convulsions, or they've got a family history of epilepsy or a family history of febrile convulsions. Most of the febrile convulsions are benign. They don't, the children recover very rapidly, and they have a normal neurological and cognitive outcome. There's no effect on their brain or on their risk of having further epilepsy. And for most children, they don't need any treatment at all for febrile convulsions, just identify the source of their fever and manage that. But rarely, for some children that have recurrent febrile convulsions, then they can be treated with either intranasal midazolam or rectal diazepam to teach the families how to give that at home. That's very rare that you need to do that. Mostly children can be managed just with safety measures at home if they have a seizure, and measures to bring down their fever if that's possible. As I said, it's important to have some idea of what a simple and a complex febrile convulsion is. And simple febrile convulsions, they're generalized in nature. They're less than 10 or 15 minutes long, and they're no more than one in a 24-hour period. But complex febrile convulsions are may be focal, or they're prolonged, or they occur more than once in a 24-hour period. There's an arbitrary definition of simple and complex, but the reason to make that definition is that children with complex febrile convulsions are more likely to go on and have another febrile convulsion, and a bit more likely to go on and have epilepsy. So I've said this already, but which children with febrile convulsions may develop epilepsy? Well, the important thing to reassure parents is that most children do not. And the vast majority of children who have one or even two febrile convulsions, they grow out of them and they don't develop epilepsy. But there are some risk factors. And if you see a child who has multiple complex febrile convulsions, or they have a family member with epilepsy or multiple febrile convulsions, or the child themselves have a neurodevelopmental problem like cerebral palsy, or they've got another underlying developmental problem, then they're probably more likely to go on and develop epilepsy. It doesn't mean they will, but they're more likely to. Now, I wanted to talk a bit about the frequency of epilepsy. We'll get off febrile convulsions, and I wanted to talk a bit about the frequency of epilepsy. And just to remind you that there's two measures of frequency, and one is the prevalence of a condition, and the other one is the incidence of a condition. And most of the data that enables us to say what the frequency of epilepsy is in a population are prevalence studies, the number of cases that exist in a population over a given point in time, whereas incidence means the number of new cases per year. They're just a bit different, and I want you to try with epilepsy to have an understanding of the difference between prevalence and incidence. Incidence being the number of new cases per year, but if children develop epilepsy, then it's a chronic condition that they keep, so therefore the prevalence is higher than the incidence. I hope that makes sense to most of you. In terms of epilepsy, the prevalence is around about 1%. If you think that the prevalence of epilepsy among all people, not just children, but among all people, is about 1%, and it's higher in rural areas in low-income countries. For sure, it's higher. The estimates for children are a little different, and they estimate that they're somewhere between 3.6 and 44 per 1,000. So the estimates vary very widely depending on the population studies, but it means that in some communities up to 4% of children will have epilepsy, and that seems very high. Somewhere between 1 and 4%, I would say, of all children in low-income countries, particularly in rural areas, will have epilepsy. The incidence is a little bit different, but that's the number of new cases per year, and there's not much data on children alone, but it's said to be 82 per 100,000 in low-income countries. I think it's more important to think about the prevalence of epilepsy and how common it is, and so to know that it's around about 1 to 4% in children in low-income countries. Now, the terminology of epilepsy is important. It's important that we have some idea of the classification of epilepsy and how to refer to different types of epilepsy. So there's there are focal seizures and there are generalized seizures, and that classification is based on the way a seizure starts. So if a seizure starts with just a focal motor movement, say of one arm or of one leg, or a twitching of the face, then that's considered a focal seizure, even if it then becomes generalized. And the reason to make that distinction between focal onset and generalized onset epilepsy is that some medications work better in focal seizures and some work better in generalized seizures. That's the main reason to make that distinction. So often when we take a history about a seizure, it's whether or not there was a generalized seizure or a focal seizure, but we have to try to take a history about the onset of the seizure. If somebody has seen it, how did it start? And that can help decide on what medications might work best in epilepsy. I'll talk more about the medications and which works best in focal seizures and generalized seizures as we go along. But this is the current WHO classification of epilepsy, but I guess it again talks about the focal onset or a generalized onset, and then it separates the focal seizures into where a patient was conscious or poorly conscious, and into those that are tonic-clonic seizures and those that are other motor seizures. This is again a complex classification, but if you just try to take a history about the onset of the seizure from somebody who witnessed it, or when you see a child having a seizure, then try to understand whether it was likely focal onset or generalized onset, then that will help. Remember, of course, that many focal seizures just become generalized, and that they're still considered focal seizures even if they become generalized afterwards. The causes of epilepsy are important because in many populations, most epilepsy is idiopathic. That is, we don't know the cause. But in some populations, some types of secondary causes, what used to be called symptomatic epilepsy, that is, the epilepsy is a symptom of some other disease, are more common. And certainly in some countries, then infection is a more potent cause of epilepsy. Now, remember, epilepsy is not the seizure a child has when they have meningitis, but if they have seizures after meningitis, once the meningitis has resolved, then they have epilepsy, but it's an infection-based epilepsy. But I guess if you think about most epilepsy in most populations is idiopathic, and we now know that idiopathic, which sort of means we don't know the cause, is actually mostly genetic. And there's some types of epilepsy that have what we call a polygenetic basis or a monogenetic basis. That means that several genes are defective in polygenetic epilepsy, or it may be related to just one gene that's defective. Or then there are many children that have just an unknown cause. They don't have any genetic abnormality that can be identified, but they still have epilepsy. Again, the secondary causes include infection or ischemia, like hypoxic ischemic encephalopathy that occurs in birth asphyxia, and children may have epilepsy after that. Or some stroke is relatively common in children. It's not as rare as what you think. We tend to think of stroke as being an adult disease, but there's lots of reasons why children may have strokes, either infections or cardiovascular disease or a thrombotic tendency. And then some epilepsies can occur post-trauma. Remember, if it's occurred during a trauma, that's not epilepsy. But if they develop seizures weeks or months or years after the trauma and they have a clear brain injury, then that's post-trauma epilepsy. Or epilepsy might occur because of a tumor, or there are some epilepsies that occur because of they're genetic in origin. They have a genetic cerebral abnormality, whereas most causes of genetic epilepsy, if you did a CT scan or an MRI scan, the brain would be normal. It's not a structural problem with the brain. Whereas when infants have cortical malformations, you can do an MRI scan or a CT scan, and the brain looks abnormal. It's abnormally structured, and that's a form of cortical malformation epilepsy or genetic cerebral dysplasia. And then there's some metabolic causes, and don't forget hypertension. I've seen many children that have seizures related to high blood pressure, either because of perhaps because of nephritis or some other renal problem, sometimes because of steroids or other medications they may be on. And so think of hypertension and measure the child's blood pressure. But so infection, hypoxic ischemic, vascular, trauma, tumors, cortical malformations, some inborn error of metabolism, and hypertension. They're the main causes of epilepsy. But the biggest cause is that we just don't know. The child has epilepsy, and it may be genetic in origin, or it might just be unknown. That's the biggest cause, and then the other ones are less common. There are a number of, in the classification of epilepsy, there are a number of different syndromes that where there's a pattern of epilepsy that can be recognized. And it's important to try to understand these. While most epilepsy has a mixture of different types of seizures, there are some identifiable patterns that can be useful for the treatment and for the prognosis and the explanation to parents. And I just wanted to go through 4 of these types of epilepsy. Now, it's not so important that you know about these, but I hope that when I explain them, you'll be able to see why they fit a different sort of pattern and why it might be useful to be able to identify this type of epilepsy from some other type of epilepsy. So we'll talk about these ones. First of all, an epilepsy, a clinical syndrome called Benign Rolandic epilepsy, another one called childhood absence seizures, another one which is called juvenile or adolescent myoclonic seizures, and then infantile spasms. And some of these epilepsy syndromes have quite a good outcome. They usually resolve spontaneously. Many of them don't need treatment. And then some of them have a much poorer outcome. They, like infantile spasms, where they generally have ongoing seizures, and it evolves into different forms of epilepsy. So I'll talk about each one of those. Again, it doesn't matter whether you remember these 4 types of epilepsy syndromes, but it can be useful if you can recognize these. Benign Rolandic epilepsy is relatively common in children. So as pediatricians, we'll often see children, otherwise well children, there's nothing wrong with them, but they then start having focal seizures. And it's usually at night, often in the early hours of the morning, the parents will notice their child having a seizure. And it can begin in an older child with sort of an aura, so a tingling in the mouth, or sometimes the parents hear a grunting noise. Their speech can be affected, and it may develop into a generalized seizure. So this is seizures that are just happening in the early hours of the morning, and by the next day the child may feel a bit sleepy, but they generally within the day get back to their usual state, and they're playing and functioning normally. But it's of great concern to parents who the onset is usually between 3 and 10 years, and it occurs in children that are previously quite well. They've never had any, generally never had any brain injury or meningitis or trauma or anything like that. They're not preterm babies. They're just otherwise normal children. Now, mostly these are the children may have a few seizures, again, usually occurring at night, but they generally become seizure-free by the age of 16, often much earlier than that. It is the name Benign Rolandic. It's benign in that it usually resolves spontaneously. It doesn't usually develop into some more severe form of epilepsy, and these children rarely have seizures during the day. It's called Rolandic because there are particular abnormalities on the EEG called Rolandic spikes. That's the way to diagnose it, but mostly I've diagnosed it just clinically based on that clinical story in a child who's otherwise well. you don't diagnose benign Rolandic epilepsy if the child's having daytime seizures, if they're having other forms of seizures, if they have neurodevelopmental problems. But if they're otherwise well and just having these nighttime, early morning seizures, then it may be benign Rolandic epilepsy. Now, if the child's having more than 2 seizures, then most parents want that treated. And I usually put the child on some carbamazepine to try to control their seizures, but it's not necessary always that you'll use medications to control benign Rolandic epilepsy, because it has such a good outcome, because it resolves spontaneously. Again, important to try to recognize this syndrome to be reassuring to parents. The next clinical syndrome is called childhood absence epilepsy. And again, benign Rolandic epilepsy causes about 15% of epilepsy in children, and childhood absence epilepsy causes about 12%. Again, the onset is somewhere between 4 and 10 years. And absence seizures are important to recognize because they're often very difficult. They're not associated with generalized convulsions usually, but the child just becomes unconscious. They may be sitting in a classroom and then they may have a blank stare on their face, and they may have a little bit of eyelid flickering or facial twitching, but usually it lasts for just a few seconds, but they won't have any awareness that it's actually happened. Occasionally with absence seizures, the child will collapse, fall down, but if they're standing up, but often it's so brief that they're scarcely aware of it. And sometimes children with absence seizures, they just, for example, in schools, they're doing poorly in class, and because they're having frequent absence seizures, and sometimes people who are observing it may not even notice that the child's having a seizure. Most of these children will grow out of childhood absence epilepsy by the age of 12 years of age. Sometimes children with absence seizures can have other more generalized convulsive seizures, and that's how it becomes recognized, because they're recognized as having a generalized seizure, and then someone says, well, they've been doing poorly in school and they've been blanking out, or when, at various times of the day, and you start to think, well, maybe they're having absence seizures. If they've just got childhood absence epilepsy, then again, it's a relatively benign condition that resolves spontaneously over time in most children, and it usually responds very well to medications. It's a form of generalized epilepsy, but and it will usually respond well to sodium valproate is what we usually use to treat absence seizures. The next type of epilepsy is juvenile, or I think of it as adolescent myoclonic seizures, because it almost always occurs in adolescence. And these children can have one of 3 types of seizures. They can have muscle jerks in their upper body typically, and they can sometimes have tonic-clonic generalized seizures, and sometimes they have absence seizures where they just blank out. Again, a bit like benign Rolandic epilepsy, it often occurs when the child just wakes up. And again, medication is very successful in controlling these seizures. Most of these seizures, again, a child will grow out of them, but for adolescents, it's really important to recognize what triggers them. And if kids are very tired, if they go to bed very late, or they have some sort of stress, then that can, in a child with myoclonic epilepsy, that can trigger them having seizures. If they've drunk alcohol, or they're exposed to flashing or flickering lights, that can be a trigger for some adolescents too, to go into these types of seizures. Tiredness is the most important one, regardless if they're, so kids who have this type of epilepsy need to think about their normal sleep-wake routine. And again, it usually is successfully treated with medications, but not so if they're continually exposed to these sorts of triggers. And then the last epilepsy syndrome that I wanted to mention is infantile spasms, or what's called West syndrome. And it's a much more, not a benign form of epilepsy. And it's usually the onset is in the first year of life. It's hence the name infantile spasms. And most children have had a previous brain injury. They might have had hypoxic encephalopathy as a newborn, or they may have had meningitis or encephalitis or cerebral malaria, and they end up with some sort of ischemic, typically brain damage, and that can lead to spasms or jerks that typically occur in clusters. And to recognize infantile spasms, it's a particular type of spasm of the whole body or just the arms and legs, and they typically occur in clusters of, you've probably seen children with infantile spasms. They may occur in clusters of 10 to 100 individual spasms of the arms and legs. Now, many of these children don't respond very well to medication, the typical medication, and sometimes they get treated with phenobarbital and corticosteroids, because that can sometimes work in infantile spasms. And most of these, many of these children go on to develop problems with learning or behavior. Some of them can grow out of it, they can get better, but many go on to develop other epilepsy syndromes throughout childhood. So this is a more harder to treat condition, whereas benign Rolandic epilepsy and juvenile myoclonic epilepsy and childhood absence seizures, they're a bit more satisfactory to treat, and the children often grow out of the condition, or certainly you can get their epilepsy under good control. Now, I wanted to talk a bit about anti-epileptic medications now, and because there are some important principles, I think, about which medication to choose. Now, I know most of us have fairly limited medications. You might only have phenobarbital available, or maybe sometimes have carbamazepine, or sometimes have sodium valproate, but it's important to sort of know why you might choose one type of medication over another. And when a child's epilepsy is not well controlled with just one, how do you select a second medication? Like, what would be the principles by which you choose a second medication? Now, when you're choosing a first medication, you need to choose it based on, if you can, based on the seizure type, whether it's focal or generalized. If you can't detect whether it's focal or generalized, it doesn't matter too much. But if you can, if a child does have just primarily focal epilepsy, then carbamazepine is probably the better medication. If they have more generalized onset of seizures, then sodium valproate or Epilem is the best medication, and then there's other medications that are good, like phenobarbital or other medications. But it's just useful to try to make that distinction between focal and generalized epilepsy in choosing medications. Of course, the choice of medications depends on what's available and what medication you have, reliability of access. There's no point putting a child on a medication that they might get only for a week or two and then not have for a month or two if there's limited access, or the cost of medication is so high. There are many of these medications have some side effects, and often the side effects you want to avoid differ at different ages. And so some of the side effects affect children in different ways. And I know many older children who don't like taking phenytoin, for example, because it causes them to have gum hypertrophy, and it causes a cosmetic effect that they don't like. Whereas for other children who are at school and might be struggling at school, then taking phenobarb can make them more sleepy, and they don't like that, or their parents don't like that. So you want to have the right side effect profile for the child. And sometimes it's just a matter of trial and error. You try one and you see how it goes, and then you find out whether it worked in terms of reduction in seizures and also in freedom from side effects. And so that's how you choose, trial and error usually, but also a knowledge of the seizure type the child's having. Now, many children have more than one seizure type. So in some ways, you choose a medication based on if they're having focal and generalized seizures, then you put them on a medication that will manage generalized seizures and probably have a good effect on focal seizures as well. I'll just go through this in brief. I've mentioned most of this, but focal seizures are best treated with carbamazepine, but also adequately treated with phenytoin or phenobarbital, and if you can get it, levetiracetam, which is Keppra, which is a newer type of medication. It has been around for a long time, but it's not as widely available. Carbamazepine, though, is a very good treatment for focal seizures. If a child's got generalized seizures, then there's no doubt that sodium valproate is the best treatment for that. But also phenobarbital is a good treatment, but it has more side effects than sodium valproate. Sodium valproate has some side effects, but not as significant, usually significant effects on development as what phenobarbital does. Levetiracetam is virtually free of side effects. It's a very safe drug, but it's not always available. So I wanted to talk a bit about the mechanism of action of these medications, because they have it helps us choose what type of medication to use, and also to know whether the medication will have some interaction with other medications the child might be on. This is important, that we have some idea of the drug interactions between anti-epileptic drugs and other drugs. And it's mostly because of effects on the liver enzymes. There are different mechanisms of action. I suppose it's first important to say that we don't always know the exact mechanism of action of any anti-epileptic drug. We sort of have some idea of one or two mechanisms of action of these drugs, but we don't know precisely what the mechanism of action is. But you can put them into various categories, and there are drugs that cause sodium channel blockade, and that's the as you know, the generation of action potentials or along nerves depends on the influx of sodium into cells, and it also depends on the influx of calcium into cells. And there are some medications that work primarily on the sodium channels of nerves, some that work on the calcium channels. Some medications work on enhancing this neurotransmitter called GABA, gamma aminobutyric acid, and that's an inhibitory neurotransmitter that calms the brain down. So GABA enhancing agents, they tend to suppress seizures. And then there's another medication that works by glutamate inhibition, which glutamate is a excitatory neurotransmitter, different to GABA, which is an inhibitory neurotransmitter. Glutamate is will stimulate neural activity and nerve impulses. And then there's you probably know about acetazolamide, which is a carbonic anhydrase inhibitor. So the way these medications work is not completely worked out, but it's useful to know the types of mechanism of action of each of the medications. And the reason it's useful is because if you've got a child who's, say, not doing so well on phenytoin, then it may not be useful to put them on carbamazepine because it has the same mechanism of action. You'd be better off choosing another agent like phenobarbital with the phenytoin, or changing to an agent that has a different mechanism of action, rather than adding another agent that has the same mechanism of action. That's the reason why having some idea of the mechanism of action of the drugs can be useful in choosing a second line agent if a child has resistant seizures. So I'll just go through them a little bit. I said that phenobarbital is a GABA enhancer. Remember, GABA is the inhibitory neurotransmitter, and so therefore it calms the brain down. It reduces the frequency of neural transmission. Therefore, that's part of why it causes sedation or reduction in attention, I suppose. and it can cause learning problems in some children who have to take phenobarbital long term. And that's why it used to be the most prescribed medication for epilepsy, and now it's prescribed less because of this effect on learning and development. It's phenobarbital, though, still is a very useful drug. Oops, it's still a very useful drug, and it's useful for a generalized seizures usually. But sodium valproate is a better drug. But if you don't have it, then phenobarbital can be useful. It also has an effect on bone density. And if you think about it, there are many children that we look after with epilepsy who have who their bone density is at risk, such as children who've got cerebral palsy. So if we're going to put a child who's got cerebral palsy on phenobarbital, then also think of their bone density and think what we can do about that, like giving them some vitamin D or some calcium supplements. There are other things we can do to improve their bone density. But if you have a child who's got cerebral palsy or some a developmental problem and you put them on phenobarbital or phenytoin, then their bones often get quite brittle. Phenobarb can be used for focal seizures as well, but as I say, carbamazepine is better. So if you've got access to carbamazepine, that's a better drug to use. Phenobarb, like phenytoin, is an inducer of liver enzymes, so cytochrome P450 enzymes. So what that means is that if there are drugs that are metabolized by cytochrome P450, then they will be metabolized much faster. And so therefore, you may need to give more of those drugs, a larger dose of those other drugs, if a child's also on phenobarbital. That's the implication of being on many of these anti-epileptic drugs. If a child's got HIV or TB, then particularly those diseases, the phenobarbital can interfere with the levels of other medications, which I'll explain in a little while. But just know that phenobarb is a GABA enhancer. It can treat generalized or focal seizures, and there are some side effects like sedation or difficulty with schooling, perhaps, and reduced bone density. Phenytoin is similar to phenobarbital, but it has a slightly different mechanism of action. It's a sodium channel inhibitor, and it can be used for focal or generalized seizures. But again, the other agents are better. For focal seizures, carbamazepine. For generalized seizures, sodium valproate's better. And there are some side effects again with phenytoin, particularly this gum hypertrophy that I mentioned. And there are some children that get a rash to phenytoin, and it also has a mechanism by which it depletes folic acid from the body. So children need to be on folic acid supplements if they're on phenobarbital, and they should be on vitamin D supplements. A bit like if they're on phenobarbital, they need to be on vitamin D supplements if you can. It's neurotoxic if you take too much. It's not neurotoxic usually, but if a child has an overdose of phenytoin, then they will have often confusion or slurred speech or double vision, ataxia. So if they're on too higher doses, and it, like phenobarbital, is an inducer of cytochrome P450 enzymes, which means it can interact with other drugs that are metabolized by the P450 enzymes. And therefore, you may need to use higher doses of those drugs. I mentioned carbamazepine. It's a good drug for focal seizures. Again, it is a sodium channel inhibitor, a very good drug for focal seizures. In high doses, if a child takes an excessive dose of carbamazepine, then it has some toxicity. Of course, it causes nausea and vomiting and a rash, and sometimes ataxia when at very high doses. And it can have an effect on the bone marrow, particularly leukopenia and aplastic anemia. So again, that needs to be monitored in children on carbamazepine. And very rarely it can cause this condition called Stevens-Johnson syndrome or erythema multiforme with a rash of the skin and the mucous membranes. And so if you see a child on carbamazepine who's having such rashes, then you need to stop it straight away. Otherwise, generally it's a relatively safe anti-epileptic drug. I don't want you to get the idea that all of these drugs are very dangerous, but if you are going to use them, you need to know what side effects to look for. It also is an inducer of the cytochrome P450 enzymes in the liver. And again, if you're on other medications that are metabolized by these enzymes, then you may need to use a higher dose of those medications to achieve an adequate blood levels. And now, lastly, I'll just briefly talk about sodium valproate. Now, that's a bit like phenobarbital is a GABA enhancer. So it causes stimulation of the inhibitory neurotransmitters. It's a very good drug for generalized seizures. It's also effective against some forms of focal epilepsy. So if I've got a child who's got both focal and generalized seizures, I tend to put them on sodium valproate. I think it's probably the best drug. It does have some toxicity, but that's quite rare. So liver dysfunction and pancreatitis are both rare side effects, but they can occur, and that usually once a year you should monitor a child's liver function and their lipase or amylase if they are on valproate. And if a child presents they're on valproate, and if they present with abdominal pain or with jaundice, then it's very important that you measure their liver function and assess whether or not they might have pancreatitis as well. Sodium valproate, it's important to know, is teratogenic, so it shouldn't be given to adolescent girls because of the teratogenic effect. And unlike phenobarbital, phenytoin, and carbamazepine, it's a liver enzyme, cytochrome P450 enzyme inhibitor. So it blocks these enzymes, and that means that that means that instead of if a child's on a drug that is metabolized by those enzymes, such as AZT, then if the child's also on valproic acid, they need a dose reduction, not a dose increase. Otherwise, they'll get very high levels of AZT. So if a child's on medications that are metabolized by the P450 enzymes and they're on an anti-epileptic drug, you just need to know which way the drug is affecting the liver enzymes. Do you need a dose reduction, or do you need a dose increase? And for sodium valproate, you need a dose reduction to maintain unchanged blood levels of AZT. These are some of the side effects that I mentioned. This is the gum hypertrophy in children who are on phenytoin. It sometimes occurs with other anti-epileptic drugs, but most commonly with phenytoin. And as I said, some teenagers don't like that. And erythema multiforme or urticarial reactions are fairly common with carbamazepine and some other anti-epileptic drugs as well. But again, most drugs, if you give the right dose and are monitoring the child closely, they don't have such side effects. Just to reiterate again, the inducers of cytochrome P450 enzymes, carbamazepine, phenytoin, and phenobarbital, but also rifampicin. And so the main message is that if they're on other drugs that are metabolized by the liver, that they will then go down because these enzymes are being induced. That means there's more of the enzyme, and so they can metabolize the drug faster. So you need to generally speaking, you need to increase the dose of the other drug because the other drug that's metabolized by the enzymes, the levels will go down. And similarly, if you're on sodium valproate or isoniazid, they're inhibitors of these enzymes, and then you need to reduce the dose of those other drugs, AZT or whatever it is, so that you don't get toxicity from that drug. So just to know, there are some inducers and some inhibitors of the P450 enzymes, and we use these drugs commonly, so we just need to have some idea of this. The treatment of epilepsy is very effective, and most children can, if you go through this process of trial and error, getting the doses right, managing the child's epilepsy and trying to characterize their epilepsy and choose the right drug, then 70% of children can achieve seizure freedom with medical treatment, with the initially prescribed drug. So 70% respond to the first drug you put them on. About a third or 30% are resistant to treatment. And the way you manage if they've still got ongoing seizures is, first of all, if you've chosen an anti-epileptic drug, then I tend to increase the dose to the maximum dose as long as there's no side effects, rather than adding another one. Don't add another drug if they're on a mid-range dose, unless they're having side effects. Just keep slowly increasing the dose until you reach the maximum dose, as long as there's no side effects. If they're still resistant, then I tend to start a second anti-epileptic drug with a different mechanism of action and a different side effect profile. That's why I said it's of some importance to know what the mechanisms of action are. So you're choosing one that's got a different mechanism of action to complement the first one. And usually, most children can be managed with monotherapy. That is one drug. And so when you add the second drug, then their seizures cease, then you should slowly withdraw the first drug. You don't rapidly just abruptly stop an anti-epileptic medication. You generally slowly withdraw it over about a month, so that you can then measure what's happening to the child's seizures. I wanted to say something about the prognosis for children with epilepsy. And for most children, they can lead a normal life. They can go to school, have an education, and get jobs. But there is an increased risk of mortality among children with epilepsy compared with the general population. And parents sort of need to know that sometimes that increased risk of mortality is about environmental risks. So when a child has epilepsy, they may have a fall, or they may get burnt, or they're certainly children with epilepsy are more likely to drown. So some of that increased risk of mortality relates to environmental risks, and some relates to a condition called sudden unexpected death in epilepsy, which is when children typically have a seizure overnight, and they may have some airway obstruction, or they may have a cardiac arrhythmia, and they're at increased risk of sudden death. That's very rare. And so I don't generally scare parents with that information. I just tell them about a focus on safety. If their child's got epilepsy, then you need for them to be safe around water, safe around fire, safe if they were, they shouldn't ride a bicycle if they're unaccompanied, or they shouldn't climb a tree if their epilepsy is still not under good control. So you don't need to stop them doing all activities, but parents need to protect them from environmental risks. Reasonable protection from environmental risks is what you need to do. But suffice it to say, there is an increased risk of mortality, but I generally don't scare parents with that. I generally tell them that, their child can lead a normal life, and it's really important that they do normal things with the child, and they go to school and have friends and, do normal play activities and that sort of thing. This condition of sudden unexpected death in epilepsy, there's certainly an increased risk in children with epilepsy, but it usually occurs in children who have poorly controlled generalized epilepsy. So if you can get the epilepsy under better control, then the risk of sudden unexpected death is very minimal. And as I say, it usually occurs in children who are not in remission from their seizures. And it's more common in children if they have a known cause, like they have a structural cause, an acquired brain injury or a congenital brain injury. In children who don't have any of those background causes of epilepsy, then this sudden unexpected death is extremely rare. It's been thought that maybe there's an interaction between a seizure and a cardiac arrhythmia, which is probably true in some children. It's important to know that some cases, some types of epilepsy don't have this increased risk. So benign Rolandic epilepsy, what I mentioned to you before, that when seizures occur at night, it doesn't carry that increased risk of death or sudden unexpected death. But many parents still want the Rolandic epilepsy treated, and for that reason I usually start some medications if they want it treated, knowing that the child will still grow out of it in most cases. There's been, I just wanted to, I've got 2 more slides. I wanted to talk briefly about, if you want to know about what happens to children with epilepsy in Papua New Guinea, then I recommend this paper by Dr. Kaspari, a Monda pediatrician in Goroka, and for her master's thesis, she followed children with epilepsy for 18 months, a very good study, a cohort study of children with epilepsy. And I think it's the best description of children with epilepsy in certainly in Papua New Guinea and in many low-income countries. And she noticed that more than half of them had some developmental disability of these children with epilepsy, and only a quarter of them attended school, which seemed a very low proportion of children going to school. And that injuries and burns were quite common. So again, we need to warn parents of that risk and make sure that they protect their children from risks like that. Most of the patients were on phenobarbital monotherapy, mostly because that was the only drug that was commonly available. But when epilepsy was managed, as I've mentioned, with trying to identify what medication works best, trial and error with different medications, adjusting medications properly, then many had a better outcome and much improved seizure control with better treatment and education of parents and monitoring. And so this is a very good paper. I'd recommend you read this paper to know about epilepsy in Papua New Guinea. All children with epilepsy need to have an individualized management plan, and I tend to write out an individualized management plan for every child I look after with epilepsy, and it should have these areas on it. So to describe the child's got epilepsy, the type or frequency of their seizures, if they've got other comorbidities like they've got hearing loss or motor dysfunction or developmental delay, the types of treatment that they're on, the people that should be contacted, and what parents and health workers should do when the child has a seizure. So how to safely position the child, what extra medications to take at home, and when the parent should take their child to the hospital, and when they should have a clinical review. And it can also have an emergency plan. So if a child's having seizures, then it can help a health worker, if they see the child, to know what other medications work in that particular child. So an individualized management plan is very important. I think it's important we talk to parents and families about some goals of care in a child with epilepsy, just like any child who's got a chronic condition. So you should discuss with the family what the goals of care would be for that particular child. Most of them just want the child to stop having seizures. So seizure freedom is important. You need to have some time when a child's diagnosed with epilepsy, have some education about physical safety for water and fires and bicycles and trees, etc. Many children with epilepsy don't go to school, but there's no particular reason why they shouldn't. And you need to be able to explain to parents that if the child doesn't have a neurodevelopmental disability apart from epilepsy, then they still can have, can learn at school, they can gain knowledge, and they can make friends, and school can be good for them. Many parents don't want to send their children to school because they're worried they'll have a seizure at school, but teachers and schools can be educated about epilepsy, and they can look after children. One of the goals of care might be freedom from complications of anti-epileptic drugs, and there are ways that you can avoid some of the complications, like oral hygiene can reduce the risk of gum hypertrophy, and children should be on vitamin D supplements to protect them from osteoporosis, and they should be on folic acid supplements if they're on certain medications to reduce the risk of folate anemia. Many children with epilepsy have faced stigma, and there's a need to improve their self-esteem. So finding out what they can do and encouraging that is very important. And I think just sharing knowledge about epilepsy with the child and the family is very important. And so sometimes if a child's coming to a clinic where there's more than one child with epilepsy, it's helpful if parents talk to each other and share their stories about their child and how they're looked after. So I think parent support groups can be quite important for children who've got chronic illnesses, including epilepsy. Now, like I said, it's important to have a positive view of epilepsy, that 70% of children can be seizure-free with treatment and live happy and productive lives. And there's a lot of stigmas around epilepsy, so that people might think it's contagious, or they're possessed by evil spirits, or they need to hide their child away and not have them socially interacting with other children. This is very important to address, I think, with families. And I would think that education starts with the immediate family, and then sometimes our role can be a wider education of a family or a school or even the community about epilepsy and how it can be treated and how children can have a good outcome. So that's what I wanted to say about epilepsy today. We've gone through lots of things: the classification of it, the definition, the different types of epilepsy, a few epilepsy syndromes that you can recognize clinically, and the medications and what their mechanism of action is and how you choose one or another, and then a few other things as well. So that's all I want to say about epilepsy today, but I'm happy to answer any questions if anyone's got any. So I'll stop sharing my screen now and stop the recording.